Welcome, everyone, to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation's educational webinar series. I love doing these informative webinars as I'm also a patient living with MPA vasculitis, like many of you. I've hosted many webinars for the Vasculitis Foundation, and honestly, until recently, I didn't know anything about today's topic, so I'm excited to learn more about refractory vasculitis with Dr. David Jayne. But before we get started, I want to go over a few housekeeping details to make you all comfortable. This is a live webinar, and we've muted everyone except for Dr. Jayne and myself to reduce the background noise. We're also recording the webinar so others can view it soon on the Vasculitis Foundation website. After Dr. Jayne shares some information with us about refractory vasculitis, we will have the opportunity to do questions and answers with him. And we have some questions that have been submitted in advance, but we will also take your questions today. So to ask questions, look for the Q&A section at the bottom of your screen. If you don't see it, click the three dots to the far right of your screen that says More. You can put those questions in the Q&A section at any point during today's webinar, and I'll take a look at them when we get to the time when we answer questions. And about those questions, we'd like you to remember Dr. Jayne cannot give you specific medical advice about your medical situation. He will do his best to answer questions thoroughly without advising you personally. And I did also want to say some people have mentioned in previous webinars that the chat box or the Q&A box was distracting. Just close your chat box or your Q&A box. You won't miss a thing. Then you won't be distracted. And now that all the housekeeping is done, let me begin by introducing Dr. Jayne. So Dr. David Jayne is the director of the Vasculitis and Lupus Service at Addenbrooke's Hospital in Cambridge in the UK. He's also the professor of clinical autoimmunity at the University of Cambridge. He trained at the universities of Cambridge and London and in nephrology at Harvard Medical School in Boston in the USA. Dr. Jayne worked at Imperial College London, St. George's Hospital London, and St. Helier Hospital Carshalton before joining Addenbrooke's Hospital in 2001. And Dr. Jayne is also the co-founder and current president of the European Vasculitis Society. He's a member of the Renal Association, the European Renal Association, and the American Society of Nephrology. And welcome, Dr. Jayne. We're so happy to have you here today. I was mentioning that I had not ever heard of refractory vasculitis before, and I'm wondering how many of you had heard of it before you signed up for this seminar. Just if you have a screen on, you can do a show of hands if you have heard of it before. If not, what we're going to do is a poll at this point. The poll is basically asking you if you've been diagnosed or if a doctor's ever told you that you have refractory vasculitis. So if you want to, everybody should be able to see the poll, and I'm going to give you a little time for our participants to get their answers in here, and then we will end the poll and share the poll shortly. This is not scientific, it's just we're curious, we'd just like to know. So it looks like 13% have been told they may have refractory vasculitis, and 87% have not. Okay, thanks so much. And now, Dr. Jayne, now that we've finished with our poll, we would love for you to share your screen and tell us all about refractory vasculitis.
Okay, so can you see my slides?
We see it great, thank you.
So that was really interesting because the figure on that poll was, I think, around 13-14%. We usually think of a figure around 20-25%. So it's not that far off. So I'm coming to you from Cambridge, United Kingdom, where it's getting towards the end of a nice summer day. And I work in this campus to the right, which is this large sprawling campus about 2 miles south of the old city centre of Cambridge. And I've been fortunate to work with vasculitis patients now since the late 80s. And I sort of joined at the beginning of the ANCA days when the blood test ANCA was first discovered and associated with vasculitis. And For the last 20 years, or a little bit longer now, I've been involved with the European Vasculitis Society. So this came together, funded by the European Union, recognizing that vasculitis was a rare disease and that vasculitis patients were underserved. And so they gave us money to collaborate together and to perform a number of clinical trials that were performed over the last few years, which have helped to contribute to some of the evidence that doctors use now to base their decisions. We have quite a large educational program, and we run residential courses for doctors from around the world, although they're based in Europe. And the last one was in Florence, in Italy, in October. And that attracted around 400 people. So we have a sort of educational remit. So that's enough about me. As far as today's topic is concerned, that is refractory vasculitis, I'm going to discuss really with you what I think about this term, how I think this term is useful, or at least where it should be used, and then give you a few examples from clinical trials, for example, of how frequent it is. And then I'm going to sort of run through my approaches to a patient with refractory disease and why refractory disease is important. And then just to end on a higher note, close with some of the recent, just touching on some of the recent drugs that are entering the clinic for vasculitis patients, which are important for this topic, because when we have access to a new drug, when we're allowed to use a new drug for our patients, really the first ones to benefit are those patients with refractory disease, which essentially means the standard drugs aren't working. So new drugs are sort of important because they will benefit that patient group. A consistent problem with vasculitis over the years is communication. The words are difficult, and the words have meant different things to different people. And even terms have changed. So we now have GPA replacing Wegener's and EGPA replacing Churg-Strauss. But we have terms like polyarteritis, which really still cause a huge confusion. Some people, like the cartoon on the right, think they understand very clearly what polyarteritis is, at least in their minds, and other people are wholly confused as to what this term polyarteritis means. And that's just between doctors and patients, or doctors and the wider community. Again, there's the opportunity for a lot of confusion as to what words mean and what expressions mean. And some of the important advances that have been made is really just to agree what words mean, to agree what definitions mean. What is vasculitis? What is GPA? What is advanced arteritis, for example? So if we start talking about it, the person we're talking to has a similar concept about this illness than the person doing the talking. And it's rather the same with refractory vasculitis. Refractory is a word which is bandied around, which is used in various different concepts. But from the medical point of view, or at least from my point of view, it has a fairly precise meaning. And when I talk to a colleague and suggest a patient has refractory vasculitis, then there's a particular meaning of that term that I'm trying to get over. And I'm going to try and share that meaning with you today. So, of course, with vasculitis, we start by talking about the different syndromes affecting large vessels, medium vessels, which you can still see with the naked eye, and then small vessels, which essentially are microscopic and you just can see down a microscope. And then I'm sure you're all familiar with the terminology, the ANCA group affecting small vessels and giant cell arteritis is the major categories affecting large arteries. And this may all seem to be quite simple now, but I assure you that when you approach this subject in the 1980s, or early 1990s, it was very confusing. And even across the Atlantic, there were big differences in the way these words are used. And it was very much thanks to Charles Jeanette, who's standing here holding a glass at the bottom on the right, who convened a series of meetings that produced consensus amongst vasculitis doctors around the world as to what these words meant. And this was a meeting actually in 2012, which was the last time a consensus meeting was convened, and we're probably due for another one. I'll just point out in the middle of the top is one of the Japanese pathologists, and he said, I understand you're changing all the names. You're changing Wegener's to GPA, and you're changing Churg-Strauss to EGPA. Well, you can't change Kawasaki because he's still alive, and he's a very famous Japanese doctor. So Kawasaki disease was not changed. Okay. So really the first attempt to talk about these words was a meeting brought together by EULAR. EULAR is a European rheumatology organization, and it's been very successful at convening meetings that then issue statements or recommendations in how to approach diseases, how to diagnose diseases, and how to treat diseases. And I was part of a group that had a meeting about clinical trials and about terminology way back now, and this was published in 2007. So we talked about disease phases, and this becomes important to try to place where the term refractory fits in. So we talk about the prodrome. So the prodrome is the symptoms the patient has had, or possibly things that have happened to the patient caused by vasculitis that precede the diagnosis. And typically in GPA, this prodrome is 6 months long. In EGPA, it can be much longer, with asthma and sinus disease going on for several years before the diagnosis. For some conditions, the prodrome is very short. So something called Henoch-Schönlein purpura or IgA vasculitis, it's pretty well immediate. It happens in a few days. We then get to the phase of diagnosis and induction therapy. And the concept of induction therapy is to eliminate any signs that the disease is active, to sort of put out the fire, just stop the vasculitis, stop it from causing any more damage, to switch it off, if you like, as well as we can. And then we talk about the remission phase, which is when we use drugs over a longer period of time, typically 2 to 4 years, to prevent the disease coming back, because unfortunately many of the vasculitides have a tendency to return. And then we talk about the off therapy phase, which is when all the drugs are stopped. Hopefully the patient remains well, but we usually keep them under occasional long-term follow-up for a number of reasons. Clearly, patients in remission can have a relapse when they then return to the diagnosis and induction therapy stage, and this can happen while they're on remission treatment or after they've stopped remission treatment. In fact, particularly after they've stopped remission treatment, we can still see relapses. So refractory disease is really the other choice once a patient has been diagnosed and has had induction therapy, if they don't manage to achieve a remission. Now, clearly, the remission is the goal, and we would hope the majority of patients will enter remission. But if they don't enter remission, they have refractory disease. And then, of course, the plan is that maybe with additional therapy, they'll then go back into the remission phase. Identifying that a patient is heading into the refractory group is particularly important for many reasons. One is because then you can stop drugs that are clearly not working and may be harmful or toxic to the patient. And the other is that these patients have ongoing activity and they're going to potentially suffer more tissue damage. So as soon as you can bring in another drug or reorganize the therapy to get control of the disease, the better, and get that patient into the remission phase. Now, in the meeting that I mentioned in 2007, we defined what all these terms meant. So remission meant there was no disease activity. Some of you may be aware of a tool we use called BVAS, stands for Birmingham Vasculitis Activity Score, which is a sort of checklist, if you like, that doctors use to check there's no activity in the skin, the eyes. It's a systematic checklist throughout the body. We talk about response, and response is something we talk about early in the first few weeks after we started treatment. And it basically means you think you're getting somewhere. We think the patient's improving. They're not there yet, but they are responding. And we discussed what relapse was, which is return of activity. And we discussed what's on the bottom of the slide, what's called a low activity disease state. Do you often find these sort of terms in inflammatory disease, so in arthritis or in other inflammatory disease? And this is where perhaps the physician's not completely sure, patient still got some symptoms, we're not completely sure that we've suppressed everything, but we've suppressed pretty well most things. And we have this so-called low disease activity state. We try and avoid using this term as much as we can. But in reality, there are some situations in treating vasculitis patients where you're truly not certain that you're really on top. It might be a patient with vasculitis affecting their kidneys with nephritis, in which there's still some abnormalities in the urine when you test the urine. It might be a patient with GPA, with nasal inflammation, who still has ongoing nasal pain or bleeding, and you're not completely sure whether that's activity or not. So we have this low disease activity state. So what is refractory? And so we've defined refractory as really occurring in 3 different places, if you like, over the disease course of a patient. The easiest is the patient who simply doesn't respond to treatment at all. So they make the diagnosis of vasculitis made, and they continue to deteriorate, however that's measured. That we call progression. And we would identify that fairly rapidly, but certainly within 3 or 4, maybe 5 or 6 weeks, depending upon the type of vasculitis. Then the next category is those patients who fail to achieve a response. And we mentioned a response in the previous slide. We put in a time here. The time is a little bit arbitrary because it slightly depends on the disease and the type of treatment, but we put in 6 weeks. Or enter a remission by 12 weeks, and a remission meaning no activity at all. And again, 12 weeks is a little bit ambitious. Some patients take a bit longer, but 12 weeks we think is a goal that, the goal should be that patients get in remission by 12 weeks. This is slightly influenced by steroids because everyone wants to reduce steroid doses and minimize steroid doses. And the goal is that by 12 weeks, at least you've got the steroids down to a fairly low dose, which shouldn't be causing much in the way of side effects. So when talking to patients, you can say, yes, I'm afraid we are going to have to use high doses of steroids, but by 12 weeks, we really hope to get them down to a low level. And then the third category is those patients who get into a remission, but then relapse. And then they get in remission again and then relapse. And they keep relapsing. And basically, with standard drugs to prevent relapse, they just don't work. And that's what I've said, failure to prevent relapse with acceptable treatments. So these, if you like, are the definitions of what is refractory disease. And you can see this is all built around this concept of activity, disease activity. So how do we approach a patient with refractory disease? The first thing is to consider that the patient is affected, and you will be only too aware of this, but this slide is very much to talk to doctors and healthcare professionals. That treating vasculitis is not just about switching off the activity and preventing relapse, top right. It's lots of other things. There's preventing organ damage, which I've shown on the right. Then on the left, it's trying to minimize risks of drug toxicity. Unfortunately, the drugs we use are toxic. It's trying to improve the quality of life, and this is clearly what is most important to patients. So they're in employment, they can get back to work, they can feel better, they have less pain. There's health resource utilization. Vasculitis is an expensive disease. It consumes health resources and patients, and then there's comorbidities. And as you may know, vasculitis patients are prone to a number of what we would call related diseases or comorbidities, such as infection, cancer, cardiovascular disease, and blood clots. And essentially, all of these facets of disease are driven by activity. The quicker you switch the activity off, the better all of this will be. And therefore, you can imagine that patients with refractory disease run up the highest burden of disease. They're the most likely to get organ damage, most likely to get drug toxicity, most likely to have depressed quality of life, and so on and so forth. This cartoon just summarizes in a different way. Disease activity drives damage, and we can measure this. So we're talking about the kidney. This might be a loss of kidney function. We're talking about a patient with giant cell arteritis in which it's not properly controlled. This might be a loss of vision. Disease activity drives more drugs, particularly more steroids, which drives more toxicity. Use of higher doses or multiple immune suppressives, which then broadens the risk of infection to the patient. And disease activity drives lower quality of life because the patient's symptoms aren't being relieved. They might even be getting worse. There could be then symptoms related to the treatment, particularly steroid-related side effects. And as their illness persists, this is an increasing stress and psychological burden on them, and they're more likely to develop psychological symptoms such as anxiety and depression, which itself will directly feed back onto their quality of life. But all of this relates back to the disease activity, the importance of trying to switch the disease activity off. Looking at the very sharp end, and this is patients really presenting with the most severe forms of kidney vasculitis. If we achieve early remission, which is the blue line on the left for mortality, on the right for end-stage kidney disease, you can see these patients do very much better. So we're looking at the probability of patients achieving a certain, or rather not achieving one of these endpoints. These patients do very much better than the red line, which is patients having a delayed remission at 6 months, or the other two lines, which is patients essentially not achieving stable remission, including those with refractory disease. So you can see, looking at the very sharp end of the sickest vasculitis patients, it's very important to try to avoid refractory disease and try to get as many patients as possible into the blue line, certainly to preserve their kidneys and to keep them going. So essentially, refractory means not achieving a timely remission, or not achieving remission typically within 12 weeks. I'd love to say we could achieve remission within a week. We're limited by the types of drugs that we have, unfortunately, but it's also some of the manifestations of vasculitis are a little bit like turning around an oil tanker. Even if you switch the engine off, it takes a while for the organ for the tanker to slow down and for things to turn around and start improving. So when we have a patient we suspect has a refractory disease, what are the thought processes? What should we as physicians think about? What do we as physicians think about? Well, the first thing we think about is the diagnosis correct? Now, much of my practice in Cambridge is actually being referred patients with refractory disease, and we receive referrals of patients from all over Britain. And usually they've been treated by quite good physicians who know what they're doing, make the diagnosis, put them on appropriate therapies, but they don't get to where they want to get to. They don't achieve remission in a timely manner. And then they ask us for help. And the first thing that we do is say, have you got the right diagnosis? So we review vasculitis. There are many mimics. There are many other medical conditions that can look like vasculitis. So we ask, is it vasculitis at all? And if it is vasculitis, is it what we would call a primary vasculitis? Or is it a vasculitis that is being actually caused by another disease process? And this happens in up to about 5 to 6% of patients with vasculitis. The vasculitis is not the primary disorder. The primary disorder is something else, but it, if you like, manifests, it shows as a vasculitis. And examples are infection, particularly tuberculosis, cancer, various different types of cancer. And just today, for example, I was referred a patient who had presented with vasculitis that had turned out to have a renal cancer. And the vasculitis was a syndrome, if you like, caused by the renal cancer, which is an association that's a kidney cancer that we recognize. And they have their kidney out and they're in good shape. And increasingly, we see vasculitis driven by drug abuse, typically by cocaine abuse. And this is usually patients who appear to have GPA or a GPA-like illness affecting the head and neck. And clearly, some people are not going to confess straight away that they're drug abusers, and this can cause quite a lot of confusion. Then, having sort of sorted out the diagnosis question, the next thing we ask ourselves is the evaluation correct? You know, is it right that this patient has refractory disease, or are they actually in remission, or you know, is this use of the word refractory okay in this situation? So we certainly ask the patient about their symptoms, we review their symptoms, and we try to work out what's causing the symptoms. Do they reflect vasculitic activity, or could they be due to something else that maybe the doctor that's referring us the patients get a little bit confused as to whether the symptoms are caused by activity? And then, of course, there's the tests. And as many of you know, you'll have had lots and lots of tests. And actually interpreting whether a test result is sort of relevant or not is quite an art. So, you know, has there been the correct attribution of the result to activity? You know, maybe there's another cause. You know, for example, there may be blood and protein in the urine caused by a urinary tract infection. It's nothing to do with vasculitis. So has the attribution of the abnormality, if you like, been correct? And we also see this with scans. So, you know, those of you that have had lung disease will know that you have frequent CT scans, chest X-rays. And often if something new appears on the X-ray, there's a whole process as, well, could this be something else, or is it vasculitis? So you have to think through the tests. And just a word about the symptoms. The symptoms are the real front end of the disease to the patient. The symptoms are what are with the patient all the time, and clearly are what they take to their doctor and what cause them the most problems. And by symptoms, I mean appearance of a skin rash, or joint pains caused by arthritis, or fatigue, tiredness, lethargy, a long list of potential symptoms in vasculitis. The doctor is really tasked with the question of what is the explanation of the symptoms. And there are really three major categories in a vasculitis patient. One is the symptoms do reflect activity. And this can be very simple, like a patient with scleritis, where there's redness and pain in the eye. That is always, pretty well always activity. And that will reverse with treatment. That will get better with treatment. Or could the symptoms be damaged? So you might, for example, have a patient complaining of fatigue, tiredness, lethargy, who has quite advanced kidney disease. And we think actually their symptoms, their fatigue is probably driven to a degree by their kidney failure. And this is not reversible, unfortunately, for this patient at this particular circumstance. And then could the treatment be this word I used before, some form of related disease that is quite common in vasculitis patients, such as an intercurrent infection, so what we would call a comorbidity. And these are frequently related to drugs the patient's receiving at the moment, or drugs they may have received in the past. So these are the sort of filters that we go through to try to place the symptoms in context. And this can cause a disconnect, and it can cause frustration for the patient who goes to the physician with their symptoms, and the physician comes back, well, it's not activity, I'm not going to change your drugs. And the patient thinks, well, you're not taking me seriously, you're not listening to my symptoms. And clearly the doctor's not made the right answer, because it's clearly got to try to explain to the patient what their interpretation of symptoms is, and therefore what the best management would be. So coming back to our patient with refractory disease, I'm still thinking, and what I'm thinking about now, having gone through the diagnosis and the evaluation, is the treatment correct? So we know what's wrong with the patient. Have they been put on the right drugs? Now, there are some drugs that continue to be used regularly in vasculitis patients that really don't work very well. I could give you some examples, but I don't want to in case some of you may be on them. But there are drugs, they might be old drugs, which physicians are familiar with, they're comfortable with, and they use, but actually they just don't work very well. It's a very easy situation for me because I say, oh, well, they're not on the right drugs. So are they on the right drugs for their type of vasculitis, reflecting their own circumstances? And if they are on the right drugs, are they on the right doses of drugs? Have the doses been properly adapted for their size, for their kidney function, for their age? Are the tests that we can look at that will tell us that they've received sufficient dose of the drugs? And an example could be cyclophosphamide, which we use for GPA, MPA at times, and we really expect to see some of the white counts drop with cyclophosphamide, and if we don't, maybe we've not given enough. And then with some drugs, we can actually measure the level of drug in the blood, and an example is mycophenolate mofetil, where we can track levels and check the patient's getting on the right dose. And then we ask ourselves, okay, so the diagnosis is right, the evaluation's right, the treatment's right, the doses are right, but is there a reason why the patient's not getting it? Of course, the one we always worry about is the patient is simply not taking the medication. This is what we call concordance. So everything above is right, but they're just not taking the drugs. This is really, in my experience, not a big issue in vasculitis patients, but it's a big issue in a related disease that we treat called lupus, which tends to affect much younger people who struggle much more with concording with their therapeutic advice. Or could it be the patient is intolerant and maybe they've stopped the medication because it really makes them feel awful, or they've had some side effects on the medication and that hasn't really fed through to the treating department? And of course, intolerance is a big issue. Maybe of any of the therapies we use, 10 to 20% of patients will be intolerant. Then it could be the drugs have not been delivered. So, this is not that big an issue with tablets, although there are sometimes reasons why tablets don't get absorbed. But for example, injectables, and some of you may be on injectables, for example, Tocilizumab for giant cell arteritis. I have had patients who don't like injecting into the skin, so they would just inject it through their clothes, maybe, and not into their skin, and it runs down their leg, and they think they've given themselves the drug. It hasn't been delivered. And then, have you waited long enough? A drug like Rituximab actually takes, a couple of months to work at least. So have you waited long enough? So these are the sort of things that would go through my mind. And having got there, that you've gone through all of those stages, you've now decided that everything is square, the patient has refractory disease, they really are failing on the correct medication, then you have a challenge. What do you do? So the first thing is, can we optimize the current therapy? And what we mean by optimize the therapy is usually increase the doses. So we don't change the drugs, but we give higher doses if we think it's appropriate for that patient and they'll be able to tolerate it. And then we have the question, do we add or do we switch? So do we add, so a patient may already be on 2 or 3 medications, we're adding another one on top, or do we switch? So we stop one and we start another. In general, adding is more dangerous because the toxicity of these therapies tend to summate. They add on top of each other. So if you're adding a third drug to 2, you're adding the risks, typically risks of infection. But adding can be quite effective in certain settings. So when you're adding therapy, you're thinking carefully about how robust the patient is, how much you're driving up their risks of some form of serious side effect that's going to get them back in the hospital, or to what extent can you mitigate or manage those risks. And a good example of an adding strategy is when we add rituximab to cyclophosphamide or cyclophosphamide to rituximab in ANCA vasculitis. And there are scientific reasons why this combination works really quite well together, what we call synergy. But there's no doubt the combination is more toxic than either of these drugs on their own. But this is a combination we use quite frequently for refractory disease. And I mentioned a little bit earlier trying to mitigate or reduce some of the risk. And one way we might do that is reducing steroids. So we might put this combination together, but then reduce the steroids quite quickly because we know that steroids contribute to the risk of infection and other side effects. With newer drugs, switch is preferable if there is a good alternative, because by switching from one drug to another, you're probably not adding to risk, but you're going to add to benefit. So it's a nice sort of balance in the risk-benefit equation. And a good example of two good examples of newer drug where we might do the switch is Tocilizumab for giant cell arteritis, say in a patient who may be on steroids and maybe methotrexate for their giant cell arteritis and have a relapse, and stopping the methotrexate and putting them on Tocilizumab, or stopping the steroid, putting them on Tocilizumab is a good choice, and that's effective. More recently, we have a new therapy I'll mention towards the end called Avocopan for ANCA vasculitis. And this is really being used as an alternative steroid, but we're using it in refractory patients, and we're sort of switching people from steroids to Avocopan. So, but these tend to be quite expensive, tend to be newer, and therefore cost can be a barrier for some patients. And then, of course, while we're doing all this, running through our mind, or at least this is the question we ask our juniors, is how will we know what we've done is working? So it's always important to have a clear idea of what the end point is. How do we actually know, how are we confident that we've actually got that patient to remission? That can be easy. A patient with a skin rash or arthritis, it's pretty obvious when you've got to where they want to get. Some patients with other disease manifestations, it can be really quite hard to work out. For example, with neuropathy or with central nervous system involvement, scans may not be that helpful, how you know you've actually got the patient into remission. This is just a couple of examples, these are quite old, of a refractory disease. So the upper, there's two old chest x-rays, and the abnormality of the chest x-ray is this, I'm not sure if you can see my pointer, but is this shadow on the left-hand side. This is a Wegener lesion or a EGPA lesion. And this young girl had come to us having failed cyclophosphamide, azathioprine, methotrexate, mycophenolate, intravenous immunoglobulin. We gave her rituximab and it cleared. So that's a nice example of a refractory GPA. This is another young lady. This was a patient, a Japanese lady I saw with GPA, who had progressive disease, and the disease was in the back of her eye. This is this white material here, what we call retroorbital granuloma, and this had actually caused blindness in the right eye. And she also had severe headaches, and this is this white line around the edge of her brain. This is GPA vagus affecting the lining, the dura of the brain, or the meninges. And she had a lot of trouble with the medication. She had a lot of cyclophosphamide, failed methotrexate and IVIG, and with rituximab, this just cleared. So this is an example of these are old slides, but it's an example of a newer therapy coming along, treating refractory disease. So Kathy did that poll at the beginning about how common is refractory disease. And the short answer is it's not very easy to define because it depends how tightly you define it. But I was just giving you a few numbers. So this is the original trial of Tocilizumab. And basically on this graph, 100% means all patients are doing well. And as they don't do well, as the disease persists or relapses, so the lines come down. And here, if you're on Tocilizumab, around about 20%, which is the top two lines, two different doses of Tocilizumab, around 20% of patients fail, if you like. So I would say the refractory disease, if you're on Tocilizumab, is about 20%. For the two steroid groups, this is with no Tocilizumab, the higher dose in blue, lower dose in orange, it's a little bit greater in terms, by 6 months, it's 25% or more will have refractory disease. So another example is in ANCA-associated vasculitis. So this was a trial that we did way back now, really comparing Rituximab to cyclophosphamide. And the goal really was to achieve remission in everyone by 3 months. So 3 months just before 100 days is about here. And you can see about 75% of patients will achieve remission by that goal. But in the circle of those patients that don't achieve remission, which I would call refractory disease, and that was about 25%. And what do we do with these patients? Well, typically we will add in the drug they haven't had. So if they start with Rituximab, would end with cyclophosphamide, start with cyclophosphamide and Rituximab, and probably give them more steroid. And then moving to a remission maintenance strategy. So I mentioned that you can relapse once you've achieved remission. This is a study we've recently completed and published, where we have associated vasculitis patients, and these are selected patients who have a history of having relapsing disease, meaning the disease keeps bouncing back. So they're quite hard to keep into remission. And here we've compared two drugs, azathioprine or Rituximab. And again, the top of the graph means that all patients remain well. And what you can see is over time, the azathioprine patients fall off such that about 40% fail, whereas over time, and this is about a 20-month timescale, about 10% of the Rituximab fail. So we would define this as refractory disease in 10% of the Rituximab and 40% with the azathioprine. And this sort of trial, along with other data, is the reason now why Rituximab is the preferred drug to be used to prevent relapse, because the proportion becoming refractory is smaller. Have there been any clinical trials in refractory vasculitis? Well, I haven't done a systematic review today, but I've been involved in 3, and I thought I'd briefly mention them. The first trial I ever did used this product called Intravenous immunoglobulin, which is prepared from blood transfusions. And we studied 34 patients that had various types of vasculitis, all refractory to what were then the standard treatments. Fortunately, we have a lot more treatments now. And we demonstrated that although not perfect, more patients given IVIG achieved a reduction in their activity. And this was reflected with some of the blood tests. This is not really a treatment we use much now. A drug that we studied quite a lot, but is not really in widespread use for vasculitis, is another monoclonal antibody. This is a very aggressive treatment, which basically wipes out one of the white cells called the lymphocytes. And so this graph simply shows the lymphocytes all disappear once given this drug. And the panel on the right shows the 24 patients we treated in this study. They all had refractory disease, so they had all been on multiple drugs coming into the trial. And essentially the time is along the horizontal axis, and the color tells you the state of the patient. Red is their disease remains active. Pale green means they're responding, and darker green means remission. And purple means they've come out of the trial. And you can see some do very well initially and then relapse, and they're back to red again. And a few, not that many, but a few get a lot of zeros and dark green, which is clearly what we're going for. In fact, it was a disease called Behçet's disease, which is the BD, that appeared to do better than the ones with GPA, which is at the bottom of the graph. This is really put up just to give you an example of how we would approach trying to study a drug in refractory disease. Again, this is not a drug that's widely available for vasculitis. So I'm just going to close by saying a little bit about what's new, because these are the drugs that I would use now in refractory patients being referred to me. The first is Avocopan, which is a tablet called Tavneos, which is now licensed for GPA and MPA for ANCA-associated vasculitis. It can be used up front in new patients. We're tending to use it more in refractory patients. Clearly, there's a big cost with Avocopan. And we're beginning to see publications come out now of its use in refractory disease. And this study on the right, this is Leiden in the Netherlands, 8 patients with refractory disease. I think the vertical line is when they're given Avocopan, and then the colors tend to go from red to green as they move along. So it appeared to be effective for these patients. The group on the left had really run into trouble with steroids, major problems with steroids, and so they were switched to Avocopan, and they did okay. For EGPA, Churg-Strauss, the new drugs that we like are these asthma drugs, so-called mepolizumab or benralizumab, which block one of these chemical messengers that drives this cell, the eosinophil, which is really the cause of all the trouble in Churg-Strauss. Now, these drugs are not a revolution, but they are a significant advance, and they mean we can reduce EGPA patient steroid doses, and they're more likely to stay in remission. And then the drug we're looking at the moment is Obinutuzumab, or OB, which is like a super version of Rituximab, and it seems to be more effective than Rituximab. And it's entering a number of autoimmune diseases, and it's now in about 3 trials in vasculitis. And I think in the future, at least for ANCA vasculitis, patients who have treated with Rituximab and who have refractory disease will probably move to OB. Just closing, much of what I've said to you is now published, and it's in what we call recommendation statements. And we updated the European statement last year. It was actually just published 2 or 3 months ago. And this is available free to download, and we hope is a fairly accessible document. And to physicians managing vasculitis, I mean, this is just ANCA vasculitis, but there have been similar updates for the other common vascular disease. This should be the sort of go-to document for doctors who are not immersed in vasculitis all the time, because it gives both an update as to what the science is saying, but it also gives an interpretation of how that update should be used to best benefit patients. And then what we're trying, vasculitis is complicated, very complicated to be a patient, particularly when you're seeing multiple different specialists. And often the healthcare system is as much a barrier to the disease as the disease itself. And what we're trying to do, at least in Cambridge, is develop this concept where the patient is at the middle and they're surrounded by the various specialties that are inputting and specialist nurses that are coordinating their care. And although I've spent most of this talk talking about drugs, at the end of the day, the people are more important than the drugs. And I want to acknowledge my medical colleagues in Cambridge that I work with, and then particularly the wonderful research nurse staff, because I'm sure you as a patient know that having a nurse that you can turn to talk through things, who has experience of the disease and the drugs, is invaluable. So I'm going to stop there and be very happy to take any questions.
Okay, thank you so much, Dr. Jayne. What's great is that your presentation answered like lots of questions already.